So we go back to our familiar bar here of all green and autism and all the various behaviors derived from the ADI and the ADOS that we associate with it. And what I'm going to do now is carry you through some of the childhood anxiety syndromes or disorders. The first one here is social anxiety, or what used to be called social phobia. Social anxiety is a syndrome of anxiety that occurs when an individual feels that they are being somehow scrutinized. They're being watched, they're on the spot, they have to perform. There are other people looking at them, they're being evaluated in some way. When does that happen? It tends to happen when people meet new people, when they're in situations like this, or they're having to perform in some way. That's when it tends to come up. Now, we know that kids with social anxiety disorder just alone, and there's evidence from this, have a number of behaviors that some people could describe as perhaps related to autism. So, for example, many kids, if not most kids with social phobia or social anxiety disorder, have real gaze avoidance. They do not like looking at people, particularly if they don't know them. So you hear this story of, well, at home it's not too bad. He's actually not too bad, but yeah, the teachers have always said he won't look at anybody, he won't look at her, he's always looking down, and pediatrician as well. Kids with social anxiety disorder, not unsurprisingly, also have difficulties developing peer relationships because they don't have the comfort level to want to interact, and over time, practice breeds success, and lack of practice breeds lack of success. They're more isolated, and their social skills start to fall further and further behind, and they get more and more troubles having social interaction. They can also have difficulties with conversation. So there are some areas here that overlap. We talked about selective mutism, which is kind of, in my view, a cousin disorder to social anxiety disorder. It's kind of social anxiety disorder that A tends to happen more with girls, and B tends to happen more with associated language disorders. So it's kind of a variant. But it does bring to the table some new aspects. So kids with selective mutism can be a little odd in terms of the way they use language. And so some of these repetitive, odd communication issues can get more and more emphasized or more prevalent there. A little bit older, and we'll talk about kind of age ranges on these things, but generalized, GAD is generalized anxiety disorder. It basically means worry. People who worry, people who are anxious about things going badly. And individuals, kids with anxiety disorders, generalized anxiety disorders, can also have some difficulties that overlap with what we see in autism spectrum disorders. But again, you see there are large areas of red. Obsessive compulsive disorder, OCD, is an anxiety disorder as well, and it's somewhat unique, and it brings to the table something a little bit different in terms of anxiety, which is that it brings some of those repetitive components to it. And we were talking earlier about some of the rituals and compulsive routines. And so you can see these kids get very focused on certain things, often anxiety-provoking things like disasters or germs or so forth, but they can get quite preoccupied with it. They can also develop a lot of really elaborate rituals that are designed to neutralize the anxiety. And that's the key here, Miriam, is that the ritual compulsive behavior of OCD is designed to neutralize anxiety. What is OCD? Obsessive anxiety. You are worried about something, it comes into your head, the world is going to end at noon unless I do something. And the unless is the compulsion. The compulsion is designed to neutralize the anxiety. Unless I leave the room right now, the world is going to end at noon. So I got to go. Bad joke. That's the pairing. Whereas the compulsive behaviors of autism are not generally designed to neutralize anxiety. They may be a release when the kid engages in it, but they're not really designed for that purpose, or they're not conceptualized for that purpose. Now, any of us who see kids with anxiety disorders has another issue with DSM, which is the way that they describe childhood anxiety disorders is very problematic. It's derived from adult mental health and adult psychiatry. And in adult psychiatry, it's not unusual for us to be able to diagnose an individual with a panic disorder alone, or OCD alone, or generalized anxiety disorder alone, or social anxiety disorder alone. Kids aren't like that. Kids rarely will have just one of these syndromes. In fact, most of these kids have a little bit of all of them, depending on what age you're looking at. So if you have a kid, and this is not an uncommon profile, where you have a bit of OCD, a bit of social anxiety, a bit of selective mutism, and you do this theoretical mind experiment where you say, okay, well, let's say we ascribe all these different aspects that might be autistic to just the anxiety disorder, how much of that's going to get explained? You start to see a similar type of bar, although the patterns are different than what we saw before, but there's a lot of overlap, but some areas of distinction. Oh, and remember, 40% of this 580 kids have an anxiety disorder. This is not an uncommon phenomenon. So back to CJ. Are we at CJ? Yeah, CJ. Back to CJ. In the fall, the parents express concerns. There's more problems with agitation and behaviors. They get connected initially to a child and youth mental health team. There's a worker, but then the worker goes on mat leave, and then there's a drop in treatment, and things kind of fall off, and nothing's really happened. He has been put on a referral for the child psychiatrist who works on the child and youth mental health team, who has a very, very long wait time. And so there's a realization that the child's also waiting for an autism assessment. So they say, well, you know what, let them have that first, and then we'll do the psychiatric assessment. So he doesn't get the psychiatric assessment done. Around Christmas, however, things have started to ramp up, and there's a particularly bad incident when CJ is being forced to go to a family gathering, which he really doesn't like going to all the time, but now he really doesn't want to, and he lashes out, and there's kind of a thing that goes on with his mother which alarms everybody, because this is not the CJ they know. They end up with a follow-up appointment with a pediatrician where he ends up being put on a second-generation antipsychotic medication and puts on 15 kilograms. The school, again, this is back in the good school district, is able to complete a psychoeducational assessment by the springtime. And by this time, the school functioning, his academic functioning is really starting to decline. He's missing a lot of days. He's really not wanting to go to school. He's not handing stuff in. He's barely passing. The testing, however, indicates that although he's of average intelligence overall, there's lots of variability. So his nonverbal abilities are kind of average, but when you look at his verbal comprehension, language-based intelligence or cognitive development, it's actually quite a bit weaker, almost in what we call the borderline range. Also noted in the testing is that he has some real problems in areas called working memory and processing speed. So there's what I would call an uneven profile, that although of average intelligence, lots of suggestions that there are problems with the way he processes information. So the psychologist diagnoses a reading disability, written output disorder, and also wonders, because of some visual motor problems, that whether the kid may have DCD, developmental coordination disorder, and recommends an OT assessment. So CJ gets to BCAN just before grade 8 and has an assessment. And we go through our standard assessment again, and we ask about the early history, and the parents say, well, they can't really remember at this point. It's a pretty long time ago whether he had pointing behavior, whether he had proto-declarative pointing. But when you ask them that question, they say, well, he's kind of clumsy, and he's always been kind of awkward with his nonverbal movements. His eye contact has always been kind of poor, as I said, outside of the home. He is hard to read. Parents can't read him all the time. He just seems to explode without any kind of early sign. So he's a challenging kid to read. Real problems with conversation are noted. And this has become increasingly evident again as this kid has gotten a bit older and they see his siblings communicate. And now in the last year or so, he's actually talking less and less. He's just kind of isolating. And when he does talk, it ends up in disagreements and arguments. And so conversations at home have diminished markedly. He's described as a creature of habit and objects loudly to any changes that are unanticipated, and also described as being, quote, rigid or black and white. When you actually probe that a little bit in the history, you don't get any clear patterns of rituals or imposition of routines or compulsions, but that's kind of the personality construct. At times he can be rude in public. Parents do worry now increasingly about him being really kind of mean-spirited with his siblings and wonder about his level of empathy. In terms of his language, they don't describe any clear examples of what we would call delayed echolalia or clearly stereotypic idiosyncratic language use, but he does have a habit of saying peculiar things. Can't really give an example of it, but he does say odd things at times. Don't recall him having any odd interests, peculiar interests, but when you ask him about early play, he wasn't a boy that really did a lot of representational play when he was younger. At the same time, his developmental milestones were all age appropriate, and it was really in grade 2 that things started to become more evident, and he was having more struggles keeping up with the other kids. But since grade 6, it's really become much more obvious. He needs a lot more tutoring, and he obviously, as I said, he's starting to fall behind. But the parents think he's smart. They do think he has trouble retaining things. He sometimes has to repeat things more and more. And now, because they're doing it so often, he's getting more and more impatient. He doesn't want to do it. He doesn't want to, and he's kind of withdrawing from that as well. The school, the parents say that at home, he's actually pretty restless, impulsive, on the go all the time, kind of touchy, irritable. Although school doesn't see any of this, and they don't really describe hyperactivity, they do think he's pretty disorganized. He's forgetful. A lot of the problems this year have had to do with incomplete work, things that haven't been handed in. And as I said, he's gotten more and more discouraged and turned off. He is frequently fiddling or picking at his fingers, but you don't hear any history of any motor stereotypies like flapping or spinning behaviors. He has, however, had some repetitive behaviors that are called stimming by the school teachers. And these, when you probe and you get a clear idea, are things like he blinks he went through a period where he was blinking a lot, and then he went through a period where making a lot of repetitive noises, and then he was doing this kind of nose wrinkling thing, and then he did a grimace thing for a while. Each of these kind of lasts maybe 2 or 3 months for a while, and then they kind of go away. Never really thought too much about it, except when the eye thing happened and the throat thing happened. They do kind of go from pillar to post from medical specialist to medical specialist to try to get this thing worked up. Nothing ever comes of it. He has lots of sensory issues, mostly kind of these aversive symptoms rather than sensory interest. So clothing bothers him, lights bother him, lots of noises bother him. Okay. Now, we are going to go back to our green and red table, and I'm going to bring our neuropsychiatric triad that we've been talking about this morning into the fore.